Okay, so small vessel disease. So these are diabetes, high blood pressure, tobacco usage. So that's number 3. Other causes to be determined: dissection, paradoxical embolus. You can also get venous infarcts in this category, and then there's always the cryptogenic or undetermined causes. This just shows some of the major vascular distributions for stroke, and you guys should know these. In neurology and during your neurology residency, you learn your neuroanatomy one stroke at a time. So I think you learn about vascular distributions, but you also learn about anatomy. So the ACAs are obviously up here, MCAs laterally, the PCAs posteriorly, and in the brainstem, you have your ICAs, your PICAs, your ICAs, superior cerebellar arteries, all going to the different levels in the brainstem. So this kind of just diagram that. All right, so hemorrhagic stroke, which I'm really not going to speak a lot about today. These can be primary, and that is unrelated to an underlying congenital or acquired brain lesion or abnormality. And again, a lot of this is plagiarized directly from this book, which is, I guess, what you guys wanted. So this is just extracted and put in a presentation form for you guys. Unrelated to an underlying acquired, so basically like an aneurysm or vascular malformation. So etiologies of this could be hypertension, amyloid angiopathy, hemorrhage related to oral anticoagulation usage, related to thrombolytics, related to antiplatelet usage. Secondary hemorrhagic strokes are related to a congenital or acquired brain lesion or abnormality. So basically covering vascular malformations, aneurysms, neoplasms that bleed, or hemorrhagic transformation. So stroke. It's the most common life-threatening neurologic disease. It's the 3rd leading cause of death in the United States, accounting for 1 in 16 deaths in adults and a leading cause of long-term disability. One thing that's important to understand about strokes, I think, is that people get better. Okay, a lot of people don't realize that and this is physicians too. I've had ICU attendings say to me, "You mean this isn't the way they're going to be? They're going to get better." People really do get better from this type of stroke. People can be hemiplegic and walk into your office in 6 months. Okay, so all you have to do is go down to rehab. And if we can get, hemorrhagic or ischemic strokes through their initial hospitalization, they can do very well. I really want to emphasize that point. 87% of strokes are ischemic, 13% are intracerebral or subarachnoid hemorrhages. 50 to 70% of stroke survivors regain functional independence. 30% are permanently disabled, and 20% require institutional care. We've actually done little breakdowns in our institution about people's NIH stroke scale and like where they end up. And people who have a low NIH stroke scale, less than 4, even less than 12, survive and tend to do pretty well. All right, this is from National Geographic, and I love this. This is your odds of dying are 1 in 1, but of different causes. Heart disease is the first one there. As you go in, cancer. And then stroke, 1 in 24, but it works its way right out. Motor vehicle collision, suicide, falling, firearms, pedestrian accident, drowning, earthquake is way up there, flood, firework discharge, 1 in 300,000. So this is a pretty interesting little diagram, I thought, but it does illustrate for stroke, that it is an important thing to think about. All right, although neuroimaging is required to accurately distinguish an ischemic from a hemorrhagic stroke, there are certain clinical clues that make you think that it's more likely to be hemorrhagic. Headache is one. Usually strokes are not painful. You don't have a lot of nerve endings in your brain. Sometimes posterior fossa strokes people report headache, but in general, that's a clue that it may be a hemorrhagic event. Nausea, vomiting, which reflects increased intracranial pressure, is also a clue that it could be hemorrhagic. High blood pressure, particularly hard to control high blood pressure, and clinical progression of a focal neurologic deficit or a worsening in their level of consciousness can be all clues of a possible hemorrhage rather than ischemic, the etiology. So what do you guys see here? First of all, what type of image is this? It's an MRI. And what type of sequence? T2 weighted imaging. And where's the abnormality? So it's a left hemisphere, right? Okay, over here you can see how the cortical ribbon is less distinct and there's some edema. Now, is this a carotid occlusion or is this a middle cerebral artery distribution stroke? It's an MCA because you're sparing your anterior cerebral artery, right? Because the ICA, the internal carotid, gives rise to both the middle and the anterior cerebral arteries. So this is a middle cerebral artery distribution stroke, and it's acute. All right. There's been a lot of recent recalibration of the definition of a transient ischemic attack, because a lot of times people come in with what would be clinically characterized as a transient ischemic attack, but then you go and you do your MRI on them, and sure enough, there's some diffusion restriction. So they've had to change the definition a little bit. So the proposed revised definition of TIA is a brief episode of neurologic dysfunction attributable to a focal disturbance of brain or retinal ischemia with clinical symptoms typically lasting less than 1 hour and without imaging evidence of infarction. So this comes up a lot, for example, in people who are going to get TPA. If a person's had recurrent TIAs, they can still get TPA if they go on and have the big one. But if they've had a stroke, they're not supposed to get TPA. They're excluded unless it's less than 3 hours. So, for example, a person has a TIA 72 hours before they have their big event. Does that exclude them? No. Clinically, they had a TIA. But now if you could do an MRI scan on them right when they had that TIA and you find some diffusion restriction, they would be excluded, which is crazy, isn't it? So, so basically, unless you have imaging to prove otherwise, the TIA antecedent to giving TPA is clinically defined. So if a person had a TIA and they got back to normal, and then they went on and had a big stroke, several days later, you still could give TPA. All right. Up to 20% of patients who have had a TIA will have a stroke in 90 days, which is pretty scary. Now, there's a score that everybody uses, especially the emergency room folks like to use, which is the ABCD2 score. And this is used to predict stroke risk at 2, 7, and 90 days after a TIA. So it's a good guideline, but it's not a hard and fast thing. So, for example, if a person had a low score, you wouldn't necessarily, you have to use your clinical judgment. But this factors in age, 1 point if greater than 60 years, blood pressure, clinical presentation, and the presentation is really about weakness or speech impairment. The duration of symptoms, 2 points if greater than 60 minutes, and 1 point if 10 to 59 minutes, and the presence of diabetes. So who should be hospitalized? The emergency room evaluation and hospitalization is recommended for patients who've had their TIA within the past 48 hours to facilitate early use of thrombolytic therapy if the symptoms recur, and to expedite diagnostic testing, particularly looking at the carotids, and initiation of secondary preventative treatments. So that's the cutoff. So 48 hours is when you start to think about maybe you could get away with an outpatient workup, provided you can do it in a timely manner. Hospitalization is recommended for those with multiple or recurring TIAs. Okay, so if they're having stuttering events, then you want to bring them in. If the symptoms last greater than 60 minutes, if they're known to have carotid stenosis, and this is felt to be symptomatic, if you have a known cardioembolic source, like you find in your evaluation that they have atrial fibrillation, if they're known to have a hypercoagulable state, or if they have a moderate to high ABCD score. If none of the above criteria are met and the results of preliminary imaging are negative, for stenosis, a period of up to 7 days until outpatient evaluation may be appropriate. So some of the TIAs can be managed as an outpatient. I just did this, sorry. don't know why it's in again. This is just showing the same thing. This just shows their stroke risk. Down here, so what the risk of having a stroke. So if they have a high score, this is what their stroke risk at 2 days, 8%, 7 days, 11%. Now there's a lot of patients, and Dr. Fletcher, I'm sure, will attest to this, that get seen in the emergency room that have a little bit of numbness here, maybe a little blurred vision, maybe a little dizziness, and it can be really hard to differentiate those people. And I have a lot of sympathy for the emergency room attendings making the decision about, who goes home, who do you send home? And of course, who you send home during the day is different than you send home in the middle of the night, because it's much harder to get the resources you need in the middle of the night. So this scoring system does provide a sort of a guideline. So I put this case in here. This is a 74-year-old man who I saw like 2 weeks ago when I was on the consult service. He had come back in after a previous episode where he had a supposed TIA. He went through the whole imaging thing, and it was all negative. And so then they labeled it as a vestibulopathy, and he gets sent out. And well, he comes back in, and he comes in having had an episode where he woke at 3:45 a.m., couldn't breathe, felt like he was suffocating. His right side felt weak and funny. He then had a funny feeling in his face, some dizziness, which he described as a room-spinning sensation. He was sweaty. He started to vomit. The vomiting lasted for 20 minutes. His wife wanted him to go to the emergency room, but he didn't want to. He did his dialysis at 5 a.m., so he was at peritoneal dialysis. He still felt a little bit weak and funny on the right side, off balance. And when he came to the emergency room, he had some residual tingling in his right hand, but otherwise he was back to normal, including walking. So, and this kind of goes through what he had recently been admitted. You guys may have taken care of this patient. I don't know any of you folks who might have, but left arm, he had some cellulitis that he had been treated for. Previous episode, like I said, in July, where he had felt like he was drunk. His MRA was negative. His MR angiogram was, his MRI of the brain showed no diffusion restriction. So based on his clinical presentation, he had an ABCD score of 6. And in fact, when you brought him in, even though he had largely resolved, he had a cerebellar infarct, which you can see here. Okay? And the thing that was unusual about him is you look at his blood vessels here, and this was the supposedly negative MRA from July the 2nd. And it looks narrow, but it was called normal. But you can see over here that it's attenuated. So it's progressing gradually. We actually looked at one from 2008 where it was wide open. So it's probably a dissection. And so he was admitted and anticoagulated for a presumptive dissection. All right, so that just kind of tells you, you use the ABCD score, but you also use your common sense. And it's a rough guideline. So once they're admitted, you do diagnostic testing. So here are some of the tests which you guys all know so well as part of the stroke order set. EKG, complete blood count, electrolytes, fasting glucose, renal function, lipid profile. A head CT scan, obviously you want to differentiate an ischemic from a hemorrhagic event. Some type of vascular imaging. All right, so this is probably one of the biggest questions people are asking me. What type of vascular imaging? So I have a slide to go through that a little bit to help you, to guide you guys. And I've got a consensus of a couple neurologists, a couple radiologists to try to make sure that what I was saying was accurate. So hopefully it'll help you guys. Vascular imaging, transesophageal echocardiogram is recommended for patients younger than 45 years of age. I tend to use it for people less than 60. Any young stroke gets transesophageal echocardiogram, hypercoagulable workup. Okay. All right, so utilization of different vascular imaging technologies. Okay, so carotid ultrasound, what's it used for? It's appropriate for rapid screening. So you're in the emergency room and you just got to get it done. You can't wait, the 24 hours for the MRA. Looking at elderly patients where it wouldn't alter your management that much. And for anterior circulation events. Okay, it covers the anterior circulation, right? The carotids feed the middle and anterior cerebral arteries. MR angiogram intracranial. It's not really, it shouldn't be used that much, really. I mean, use it to look for aneurysms, but here are some of the cases where you would look at it. If a person has recurrent transient ischemic attacks, so stuttering, TIAs. A young patient where you're looking for the more atypical etiologies, the CNS vasculitis, the intracranial atherosclerosis. Patients who have atypical presentations. So sometimes, people have these weird circulations where the whole hemisphere is collateralized. There's like a black distal carotid and you're collateralizing from the other side, and that's an important thing to know. Let's see, screening for intracranial vascular malformations and distal emboli. So basically, it has utility, but it may not have a utility as the first battery of things that you order on a patient when they come when they hit the emergency room. And a lot of times, and I've talked to the radiologists about this too, this is kind of a cool project idea, but people who have MRIs brain, MRA intracranial, ordered for stroke probably reflects some type of ordering error. Okay, that there was an ordering error that occurred, that they didn't order the extracranial MRA, or they didn't screen the extracranial vessels. And that happens periodically where people get to rehab or they get as an outpatient and you realize, holy cow, they went through a month of hospitalization and they never looked at their carotids once because somebody, and this is how I imagine the conversation went, the attending says, so what did the MRA show? The MRA was negative, and so and gets left at that, and then nobody's looked at the extracranial. So I think it's very important for you guys to keep that in mind, that that's a potential ordering error, is forgetting to get the MRA extracranial, which it goes in as MRA neck. You guys probably by now know that. MR angiogram extracranial, what's the when do you use that? Well, you use that for young patients. Why? Because a lot of times they'll have dissections and other atypical etiologies. And I actually put that in there, suspected dissection. Posterior circulation events, right? The carotid ultrasound isn't going to cover the vertebral arteries. So it makes sense to if you have a posterior circulation event, like a occipital infarct or something in the brainstem or cerebellum, you want to look at the posterior circulation. And sometimes it's useful when performed in tandem with the MRI scan. So in other words, you're sending them for the MRI, why not just do the MRA extracranial also? Sometimes you'll order, if you get one that's abnormal, the MRA is abnormal or the carotid ultrasound is abnormal, you probably want to order either another complementary study. So for example, if the carotid ultrasound shows left-sided carotid stenosis, you want to get an MRA extracranial to confirm that stenosis, or default to a CTA. Okay, so you usually, if you have an abnormal study, you default to a second study. CT angiogram extracranial is used to confirm abnormal findings on MRA or to resolve contradictory antecedent tests. Okay, so I had one patient, and this was in July, who had the ultrasound showed right-sided carotid stenosis, and the MRA showed it left-sided carotid stenosis. So, and then we did CTA, and we didn't have any stenosis at all. So I don't know what that means, and why that artifact showed up, but it was worth doing it for him, and we needed to go to that level. CT angiogram intracranial to evaluate for suspected intracranial vascular malformations, and which would change the management and to evaluate for atypical etiologies of stroke, such as CNS vasculitis. All right. Have I confused you more, or have I clarified it? I hope I've clarified it. Does anybody have any questions about how these are ordered? Because it's like the biggest question I get when I'm rounding. All right, now I can make this available to you, and I'll put it in our little handbook at some point. All right, so emergency evaluation of stroke. You want to identify patients with possible stroke, especially those eligible for acute interventions such as TPA, and to differentiate stroke from mimics, to identify potential causes of stroke in order to implement early secondary prevention. So this little book had a diagram which I would have liked to have incorporated, but I didn't. So they talked about, one of the things they talked about in here was high-risk cardioembolic sources. But another nice diagram in here is about stroke mimics. And so mimics of TIAs, they mentioned benign paroxysmal positional vertigo, metabolic derangements, migraine equivalent, myasthenia gravis, seizure, subarachnoid hemorrhage, transient global amnesia. Mimics of stroke, brain tumor, conversion disorder, dementia with a worsening in cognitive impairment, drug overdose, HSV encephalitis, head trauma. So some good little diagrams here about some other things to think about. But your stroke is the most life-threatening thing, and that's the thing you want to exclude first, and then you can start working your way out towards the zebras. The common things occur commonly. The most important piece of historical information in a suspected stroke is the time of symptom onset. So you want to know when they were last normal. They're looking at TPA, as you know. If you wake up with a stroke, you're excluded from TPA. But there actually are some recent studies that for people who have wake-up strokes, giving them TPA, and it doesn't look like the outcomes are that much. Don't look like they're any worse. Certainly not worse than for the 4.5-hour intervals. So there may be data to at some point support giving TPA for wake-up strokes if you can get there within 3 hours. But right now that's not in the guidelines. Additional historical items include vascular disease, pre-existing cardiovascular, cerebral vascular disease, the circumstances around the development of the neurologic symptoms, history of drug abuse, migraine, seizure, infection, trauma, or pregnancy. Another interesting thing I thought you can, with the computerized medical records in the hospital, we have a couple patients, just in terms of data extraction, we have a couple patients who've gotten TPA on multiple occasions and have negative diffusion weighted imaging each time they get it. And that kind of tells you something. It just makes you wonder about, if you looked at each of those patients, because you can find out who they are very easily. Any person whose name shows up twice on the list, you could look at those patients and find out, what is it? What does it actually end up being? A lot of times you think it's conversion, but they're convinced it's real. But we do see people sometimes who come in, and we attribute those oftentimes to migraine. Historical data are really related to their eligibility for therapeutic interventions, including TPA. So your physical exam should include the general exam, and you want to look at the head for signs of any trauma or any signs to suggest seizure. You'll do your NIH stroke scale, which you can see outlined. I'm not going to outline that for you here. Scores can quantify the degree of neurologic deficit, so less than 5 is mild, 10 to 15 is moderate, and greater than 20 is severe. Also, those correspond to, presumably, the size of the infarction. NIH stroke scale and other stroke grading scales facilitate communication between providers, gauge your changes over time, identifies location of arterial occlusions, provide prognostic information, and identify eligible patients for acute therapy. And so we're really trying to, make sure that especially our nursing staff are educated about the NIH stroke scales. Probably, again, once a month we have a person who has a clinical worsening after a TIA. They actually end up having a stroke, and nobody's called about it because we don't really know when the last NIH stroke scale was done. That's happened a couple times recently. Head CT is the study of choice for the emergency evaluation of stroke. Non-contrast CT scan. It excludes intracerebral hemorrhage. It discriminates non-vascular causes of their neurologic symptoms, such as a neoplasm, and can identify early signs of infarction. The presence of a large infarction is correlated with a higher risk of hemorrhagic transformation after thrombolytic therapy and is associated with poorer outcome. And I think I talk about hemorrhagic transformation later in the talk here. Head CT should be completed within 25 minutes and interpreted within 45 minutes for TPA. The role of CT perfusion and CT angiogram in acute stroke management has not yet been definitively established. I haven't used the CT perfusion at all. CT angiograms are useful, however. Sometimes if a patient has a very, you're really not sure whether they've had a stroke, sometimes you can do a CT angiogram and it's almost like a quick diffusion weighted image because you can see where there's an occlusion of the MCA or whatever. So sometimes that, I think this happened with a patient I heard about from Beaufort County Hospital. They didn't have MRI capacity, and so they did a CT. It was very questionable whether they had a hemiparesis because they were poorly responsive. But we did CT angiogram, and it showed, that they had it was a vertebral basilar event, and you were able to give TPA just because it was better defined once you've done the CT angiogram. So, all right, what type of image sequence is this? diffusion weighted imaging, right? MRI for idiots. So this is a hyperacute ischemic lesion, right? In the what would you say? All in favor of anterior cerebral artery distribution? Middle cerebral artery distribution? Posterior cerebral artery distribution? Okay. Pica distribution? ICA? Nobody's raising their hands. Okay, so this is non-participation. Okay, does anybody know what distribution this is? Posterior cerebral artery, right? It's confusing a little bit because you don't see this part involved, right? But if you follow the images up further, you can see how it went. See the PCA kind of tracks around the midbrain and comes and hugs the medial surface of the temporal lobe. So that's actually a PCA distribution stroke. Okay, MRI. So any of you guys who've rotated through neurology know how much we use the MRIs. Diffusion-weighted imaging has a high sensitivity, 88 to 100%, and specificity of 95 to 100% in detecting ischemic lesions, even within minutes of symptom onset. And then the signal gradually diminishes over several weeks. The ischemic penumbra, which is the area that is not permanently damaged, stunned brain, is... and I apologize for any typos in here because this was like dragged in a couple of days ago, and so I tried to correct it. But the ischemic penumbra is roughly approximated on MRI as the region of perfusion minus the region of diffusion abnormality. So there's an area that's permanently damaged and an area that has less perfusion, and the difference between those two defines an area that may be salvaged. And those are people that in particular you would want that permissive hypertension to be maintained in the acute phase. MRIs are better than CT in distinguishing certain types of stroke: acute small cortical strokes, small subcortical strokes, brainstem and cerebellar strokes, and in differentiating acute and chronic infarcts. And sometimes identifying little satellite ischemic lesions. Sometimes you think it's all in one area, but actually they've thrown a shower of emboli. The limitations of MRI are obvious: cost, availability, longer image times, motion artifact, and patient contraindications. So you want to do your general medical care, airway support, ventilatory assistance if necessary, oxygen, decrease their fever. There's no evidence that induced hypothermia is useful for the treatment of ischemic stroke, although it, as you guys who've been over in the heart towers know, it is used for global hypoxic ischemic injury in patients who've had a cardiac arrest, and in that whole Arctic Sun protocol and how people wake up and prognosis after that. Cardiac monitoring for the first 24 hours is really done just mainly to monitor for atrial fibrillation. Hyperglycemia is a bad thing in the first 24 hours, so any patient with blood glucose greater than 140 should be given insulin. Gosh, I don't know, do we ever really do that? Glucose should be closely monitored to avoid hypoglycemia, and that would be a bad thing too. All right, so the management of arterial hypertension. So this is probably the most common question: is where do you keep the patient's blood pressure, whether it's intracerebral hemorrhage or stroke? So there are some guidelines, and those are available, on the on our the Vidant website in the neurology guidelines. But here are some guidelines that were available from this book. It's a compromise between precipitously lowering the blood pressure and potentially compromising blood flow to the injured tissue, and the risk of hemorrhagic transformation if you maintain the blood pressure too high, and maybe you can make cerebral edema worse. So, antihypertensive should be held for the first 24 hours unless the systolic blood pressure or diastolic blood pressure is greater than 220 over 120. I think most neurology attendings get a little bit frightened by those values, and we tend to control if it's anything greater than 200 over 105, 110, somewhere in there. But there are actually studies where they've elevated people's blood pressure in the context of an ischemic stroke. And it doesn't look like they had any greater risk of hemorrhagic transformation, and the outcomes may be better. So that's maybe where we're going with this, is that you're actually going to end up increasing people's blood pressure. Blood pressure, over the long term, controlling blood pressure over the long term is obviously an important thing to think about in terms of secondary prevention of a stroke. But in the acute phase, we may need to elevate their blood pressure or at least not control it as rigorously. Spontaneous decline, and you guys have probably seen this in the stroke patients that you take care of, occurs in the first 24 hours after the stroke. First, a reasonable goal would be to lower the blood pressure by 15% during the first 24 hours. There are very rigorously defined blood pressure parameters for TPA eligibility, and that's 185 over 110. And you try to maintain the blood pressure 180 to 105 over 105, less than 180 over 105 for the first 24 hours, with labetalol or nicardipine as your preferred antihypertensives, unless it's cocaine or something related and you want to use just the nicardipine. Here are some of the contraindications, and I won't go through, in the interest of time. Am I allowed to go over just a few minutes here because of all the technical problems? Okay. All right, my clinic patients will have to wait. This is just contraindications, okay? But the ones that are, so whenever you guys won't get these TPA calls, but whenever we're screening, the first thing we do is run the contraindications. That's the first thing we think about. And almost invariably, in-house code strokes don't get TPA. There's some contraindication, whether it's a procedure or something. It's a very low probability. Now, the emergency room, on the other hand, that's high yield. I mean, so a lot of people in the emergency room end up getting TPA. So some of the things to look at really here are the 3 hours, we talked about that. But the other one to keep in mind is the previous stroke or head trauma or myocardial infarction within the past 3 months. GI or urinary tract hemorrhage within the previous 21 days. Major surgery within 14 days. Okay, so those are some of the things to think about as far as deciding on TPA. No oral anticoagulants or the INR less than 1.7, so if they haven't been compliant. Now, these TPA contraindications or eligibility changes a little bit for the 4.5 hour interval, because we have changed. People less than 4.5 hours can get TPA. The unusual additional contraindication in there is the combination of diabetes and stroke together, because that's just how the studies were done. So if they had a previous stroke, any stroke at all, not specifying the interval, and diabetes, those folks are contraindicated from getting TPA at the 4.5 hour, less than 4.5 hour window. Okay. So what type of imaging study? CT scan, right? Yeah, the bone is white, and you can see a stroke here. What distribution is this stroke in? TCA, and it is acute, chronic, subacute. What do you guys think? Chronic, right? It's a hole, so it looks chronic. There may be a little tissue here. Maybe it is subacute. I don't remember, honestly. And the other thing you see here is a little bit of microvascular disease. So you see how the ventricle kind of blends into the white matter, kind of graying out. That indicates some ischemic demyelination in the periventricular white matter. TPA outcomes. So this is the number needed to treat, which is a great statistic, isn't it, to present to patients. Average estimated number needed to treat for one patient to have a better outcome, that is greater than 1 on a modified Rankin scale, which is a recognized scale for rehabilitation, is 3.1. Estimated average needed to harm one patient attributable to TPA is 29 to 40. So clearly it's a beneficial therapy, and the outcomes have proven to be very good at much improved at 3 months. So in other words, TPA is 10 times more likely to help than to harm eligible patients with acute ischemic stroke. That's why there's a national initiative to administer it, and that's why hospitals are so well reimbursed for it, presumably. Treatment options for selected patients with major stroke. What is this? What am I trying to do? Okay, so intra-arterial thrombolytics. So sometimes you're in a desperate circumstance and they're not a TPA candidate. Well, we're still trying to refine these algorithms. Who qualifies for intra-arterial thrombolytics? There was a brief period of time where we we kind of fell off the map and just started giving IA therapy to anyone who didn't improve. And it was for about 6 months or something. And actually people did really well with it. But then we realized, well, we were being too aggressive, and we backed off a little bit. So we don't give. So we're kind of going to take the lead from our vascular neurosurgeons from here on out. And when they're ready, we'll probably start doing more IA therapy, particularly for patients who are otherwise contraindicated. And those were most likely the first population that you would identify to give intraarterial therapy. That is where you go up with a catheter, you see the occluded middle cerebral artery, and you squirt the thrombolytic directly at it, are going to be patients who've had a recent surgery of some kind, like a vascular surgical procedure. And those are probably going to be the first ones that we're going to try this on when we re-implement IA therapy for stroke. Or the ones that are really desperate, like if you have a posterior circulation, like a top of the basal where the person's locked in and it's desperate circumstances, that might be another circumstance. All right, antiplatelet agents and anticoagulation. So as you guys know, anticoagulation is a no-no in general for stroke unless you have clearly defined cardioembolic source. So, a mechanical valve, atrial fibrillation. It does increase the risk of intracranial hemorrhage, and it probably does not have any additional utility beyond what aspirin would do. Only aspirin has been evaluated in the treatment of acute ischemic stroke. Aspirin 325 administered 24 to 48 hours of a stroke is effective in reducing death or disability. Okay, there's a typo there. For patients having received lysis, that is thrombolytics, all antiplatelet agents must be held for the first 24 hours. So so where do the Plavix and Argonox and old-fashioned Tyclid fall into this? Well, they're secondary preventative measures. Okay, and I'll talk just briefly in the last couple minutes about the aspirin failure thing, whether that's real or not. Did I copy the same slide twice? I guess I must have. All right, what type of stroke is this? I'm a pathologist too, and as you guys know, I do a neuropath conference on Fridays and look at the slides. So I see a lot of the bad outcomes. I see some of the forensic cases. So this is the brainstem. Okay, what level of the brainstem do you think? Midbrain? If it's the midbrain, where's the substantia nigra? There's no substantia nigra, right? Midbrain should look like Mickey Mouse. The orientation of this is a little bit hard. The fourth ventricle's on the top. Okay? You can see some choroid plexus up there. So these are actually the corticospinal tracts. Does that help you? So what level is it? Is it the pons? The medulla? Well, you can see a little bit of the olives over here, okay? So it's the medulla. So these are the pyramids, and this is the lateral medulla. So that is a lateral medullary stroke, or Wallenberg. People love it when there's a name attached to the stroke. But we have probably one of these a month, and they're pretty bad strokes when people present. Profound dysphagia, ataxia, crossed hemisensory symptoms, but they do very well. Okay, they tend to do very well. They recover well. So comprehensive specialized stroke care and standardized order sets really can reduce morbidity and mortality. And having rehab incorporated into that can decrease their length of stay. Subcutaneous initiation of anticoagulation is recommended for immobilized patients to prevent DVT. This is less of an issue. I talk a lot about this in my intracerebral hemorrhage talk about when you can start the DVT prophylaxis, because I get that question all the time too. You want to assess their swallowing and see who can eat. Some of the complications of stroke can include cerebral edema, which tends to peak in the first 3 to 5 days. People who seem to be at risk for malignant brain edema, and that's particularly young patients where there's less atrophy to accommodate the infarct, should be transferred to an institution with neurocritical care and neurosurgical expertise. So you start to get atrophy around, 40, about when you start your residency, or when you finish your residency or fellowship. There's no role for prophylactic anticonvulsants in patients who've had a stroke that haven't had seizures. So possible neurosurgical interventions, and we see more and more of this, are people who require a drain when they develop hydrocephalus. And so a lot of times that'll happen if there's a cerebellar hemorrhage where it compromises the outflow of the aqueductus sylvius, and so they can get a ventricular drain. Some of you have probably taken care of some of the decompressive procedures, and actually Dr. Tucci was the first person to use the hinge craniotomy, which is actually where you leave a portion of the skull attached. And the advantage of that is there's no second procedure, so it accommodates the edema and then it falls back into place. It's kind of a cool procedure, and I guess he developed it because there was something technical that happened where he couldn't take the skull off, and so it just happened to work out well, and so now it's published and people use it as a technique, which is kind of cool. But so that's when you have a person who has malignant cerebral edema due to an infarct. You need to create some space, and you create a little more space in there, and so you take off part of the skull. Medical therapies for malignant cerebral edema include osmotic therapies, hot salts, everybody loves that, intubation, and hyperventilation in deteriorating patients. These are not definitive, but you can use them. So in general, they're not indicated, but they can be used to bridge to a more definitive neurosurgical intervention. Corticosteroids are not recommended for cerebral edema in the context of ischemic stroke. Now, brain tumor and other etiologies is a different story. Secondary prevention, and I'm getting ready to wrap up here. Hypertension, there's a benefit between dropping a patient's blood pressure 10 millimeters systolic blood pressure, 5 millimeters diastolic blood pressure, with a desirable blood pressure defined as 140/90, less than 140/90, and less than 130/80 in patients with diabetes or multiple vascular risk factors. In patients with diabetes, you want more rigorous control of blood pressure with a hemoglobin A1C less than 7. Lipids, you do dietary modifications, lifestyle modifications. Statins are recommended with an optimal target, which is there. You want to make sure that you don't get lost in the whole antiplatelet agent dilemma, and so you forget to talk about smoking, cessation, decreasing their alcohol consumption, and talking about having them get out and be more physically active. This is just the ACAS study. Stenosis greater than 79% in patients with TIA or stroke, and a life expectancy greater than 5 years benefit from carotid endarterectomy. 50 to 69%. Some of those folks may benefit from carotid endarterectomy. Anything less than 50%, no indication for surgery. When carotid endarterectomy is indicated, it should be done as soon as possible. If the stroke is small, within 2 weeks, and within 6 weeks if it's a large stroke. You don't want to the surgeons don't want to operate on someone who's evolving the stroke and getting worse, so they have to wait a little while. Carotid angioplasty and stenting are indicated in very specific circumstances and are probably not superior to the carotid endarterectomy. So if they have radiation to their neck and it makes it so that it's an inhospitable field, or if they are at increased risk of surgery, then they can get those procedures. I think it's just because the carotid is so available to a surgical procedure. I mean, it's just right here below the surface. So it's not a very complicated surgery by vascular surgery standards. Endovascular treatments with symptomatic extracranial disease. It tends to occur in is for patients who have posterior circulation events. In general, you try to do maximum medical therapy. There was recently a study looking at intracranial atherosclerosis, whether putting stents in and angioplasty would be beneficial. And it looked like the medical arm was doing better, or the medical arm was doing better than the interventions. And so they stopped that study early. And so the surgeons currently recommend, I'm almost done, currently recommend maximum medical therapy. Okay, this is the last one. All right, antiplatelet agents are preferred over anticoagulants. Agranox, which is aspirin and dipyridamole, may be slightly more effective than aspirin alone. Plavix may be slightly more effective than aspirin alone. You never want to give two antiplatelet agents. That increases the risk of stroke and is not routinely recommended for patients with stroke or TIA. Although alternative antiplatelet agents are used for, so sometimes this question of, is a person who comes in on aspirin has a stroke and an aspirin failure, and that's a pharmaceutical company defined kind of term. It's a procedure. It's a medication that reduces their risk. It's not like a magic tablet that makes it so that they won't have stroke. So, as people know who've rotated with me, the main thing is to make sure that they're on an antiplatelet agent. If they have recurrent TIAs, then you might want to go to Agranox. But beyond that, it's your choice, whatever antiplatelet agent you want to choose. All right, and this talks about dissections, and a lot of this is in there. Hemorrhagic transformation. This is not in the MCSAT book. And then just the CHAD score, okay, which is